Hello, Dr. Helen Erickson. How are you doing today?
I'm great. So nice to be here with you, Tommy.
Well, we want to make sure that our nurses understand the importance and significance of nursing theory. And as a young nurse, I remember the modeling and role modeling theory that you established, and I want to know how we incorporate that nursing theory in the care of patients today.
It really starts with helping the nurses understand the philosophy and reflecting in their own hearts and souls about what they believe about people and what they believe about nursing. If they don't have that first step, then the theory, as we think about it, is detached from them. And what is so important, because the client's primary source of information. In modeling and role modeling, it means to step into the other person's world, build a worldview of that, and design your interventions from that. And so if they don't have this sense of themselves, this knowing that this is what I am to be doing now, this is not a job. This is a profession, and for many it's a mission or a calling. So I think the first step to help nurses use theory, and probably any theory, is to understand the philosophy that is the underpinning of it, the foundations of it. And I would certainly say that's very true about modeling and role modeling. So I always want them to stop and ask themselves, what do you believe about people? What do you believe about yourself? Why do you think you got sick last week? You know, students would come in and say they had the flu. Well, and I would say, why do you think that happened? And they said, well, everybody's got the flu. And I said, yes, but they had it 2 weeks ago. You didn't get sick 2 weeks ago. You got sick today. Why do you think you got sick today? They'd almost always come back with one thing, and that is too much stress. So that's a very big part of modeling and role modeling. But for the nurse to understand that that is an issue, that there's mind-body relationships in human beings, and those mind-body relationships are related to how well we are, or when we're vulnerable for illnesses, how well we're able to cope with what happens to us, and so forth. So that's what I think we need to start with, is the basic philosophy.
Thank you. You know, in today's world, we use computers a lot. And some patients even have expressed to me that the nurses are more involved in nursing the computer than taking care of them. What suggestions do you have for nurses today in regards to how to better integrate what they have to do on the computer with taking care of the patient?
I would always say the same thing, and that is start with what the person says. The computer sits here, the person sits here, and you always start with here, the person. What is that person saying? And then go to your computer and see how that relates to what you find in there. Because many, many times the computers are not programmed to understand what that person is saying. You as a nurse have to understand what that person's saying in order to be able to help them. If somebody is very, very sick and they say, I cannot get better unless my dad or my son or my mother or my cat or my dog comes to visit, you need to pay attention to that, and that will not be in that computer. So use the computer as a tool, just as we use a stethoscope or any of the other instruments we have. Use it as a tool to help us to make critical judgment, to keep track of what we're doing and so forth. But the person is your primary source.
That's awesome. That's awesome. You know, what we see a lot of times in our lobby are individuals with service animals. So in your mindsight, what do you think about service animals and how they attribute to the person's well-being?
Very, 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 very important. Service animals are often used in place of humans to meet trust, basic trust needs, basic security needs. They're very important to help the biophysiology stay stabilized. There has been research that's shown that you take a service animal away and the blood pressures will go up, pulses will go up, people breathe differently, etc. You bring them back and there's a deep breath and there's a calming down. These are very important part of the human being. So in modeling and role modeling, we talk about attachment objects. Service animals are attachment objects. And we need to recognize that and know that they're just as important and maybe more important sometimes than humans in their lives. So, and I know that sounds strange, but in Modeling and Role Modeling book, first written way back in the 80s, I wrote a very important sentence. I said, we have to, as nurses, try to understand whether the support system is really a support system or is it a network? In other words, are they invigorating or are they draining? Because many, many people have people that are significant in their life and they want them in their life. They're not going to not want them there. But when they're there, it's exhausting. And they only want them there for a short period of time. That never happens with service animals.
That's so very true. That's so very true. You know, we have a great residency program here at University Health System. And one of the things that concerns us sometimes is the ability to have nursing preceptors for our new nurse residents. And we use the modeling and role modeling philosophy to encourage senior nurses to participate as preceptors. Tell me a little bit what you were thinking. Were you thinking about the preceptor when you derived your model, or what did you think about the relationship between a new graduate and a experienced nurse?
I've always thought that preceptors were very, very important, but I also believe that when you have a preceptor and a preceptee, that then the preceptee is the client. And therefore, it's very important for the preceptor to model the student's world and understand from his or her perspective what it is they want to learn, what they're there to learn, and how to mesh that in, interweave that with the professional requirements. So I think preceptors are extremely important. When I first started labeling and articulating modeling and role modeling a long time ago, it was simply because I had been practicing it for so many years and finally had found ways to label it and articulate it, and I had been invited to go around the country, different places, to present it, and people would say, where's it written? Because my intent was that nurses would learn to think like this. Nurses would understand the primary source of information is the client. I looked at charts, and we would have soaping in those days, and there would be this wonderful S, the subjective statement. The rest of it was all objective. Nurses and everybody would ignore the subjective. Oh, that's just, you know. That was the most important part.
It was.
And that's what I wanted them to understand, but I also wanted them to understand that there's science behind understanding the subjective. And so when I first started doing this, and I was running around the country, they'd say, where's it written? I'd have to say, I don't have it written, I'm so sorry. I'm busy doing it and telling. And that's how it happened to get written. So the focus was really on helping nurses learn to know what was true in my heart, which gave me the greatest of joy, and made it possible for me to deal with and incorporate and find meaning in difficult experiences. I saw so much burnout, you know, and I think when nurses really have a heart sense about what they're doing, burnout isn't a factor. So that's how it happened way back.
So let's talk a little bit more about burnout. One of the facets in your model is self-care. And so how does self-care help with burnout?
Well, self-care in modeling and role modeling has three parts. There's self-care knowledge, self-care resources, and self-care actions. And this applies to all human beings. It's important for nurses to understand self-care knowledge, which is what your client tells you, what do they know that's related to why they're sick, how it happened, and it has nothing to do with science. It happens to be what they think, okay, and what they feel. Self-care resources is asking them, how do you think you can help yourself with this? Because we may look at people and think they're very resourceful, but they may not think they are. And they may not think that what we think is a resource for them is. For instance, I've often had a number of people who've very active in a church. And I would say, you have all of your friends at the church. How about us arranging something for them to come and see yours? No, 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 no. That's not my role in the church. So that's a network. That's not a social support team. Okay, so the resources are how able are they to cope personally, physically, which is a part of the model, and what kind of resources do they have to be able to contend. The third part then is what do they do with those resources? What are their actions? Because often people, if you watch their actions and listen to what they're saying, you'll find they're doing things to be taken care of because they don't know how to do it any other way. So this holds true for nurses as well as it does for clients. We need to know as nurses what is our self-care knowledge? What do we know about ourselves? What do we know about ourselves within the context of our practice? We need to self-reflect, and we need to use reflective practice to think about how we related to people, what impact that had, what do I want to do differently, why did I do it? Is this related to something else in my life? Just a short one short story. When my mother was passing, and she was 91, and she was in the hospital. She had had pneumonia and was in the hospital, and it was in late evening, and I knew she was passing, and she had declared she did not want any advanced interventions at all. So we had decided no renal dialysis as her potassium went up and so forth. And it was about midnight, a little after midnight, and shift had changed. And so the nurses on the evening shift all understood completely what was going on. So I was sitting in the room, and I had Amazing Grace playing because she liked that. She was not responding. And I was sitting there with her, and the monitor was on because the nurses felt more comfortable to have the monitor on and so forth. And pretty soon the night nurse came in. And I was sitting on the far side of the bed. The night nurse came in on the other side, and she said, "Turn on the lights." And I said, "Oh, please, turn down the lights. My mother's asked to have a quiet time at this time in her stage. And so if you don't mind turning down that, and just turn on this little lamp over here so you can see." Okay, she did that. And then she said, "I have to check the urine bottle." I said, "Well, she has renal shutdown. She doesn't have any urine. I have to check it." I said, "Okay." So she squatted down on the floor, and there she was. And I'm on the other side thinking, what in the world is she doing? Pretty soon I hear from the other side of the bed. So, here I am, the daughter with my mother passing, but I'm also the nurse and the mentor.
Oh, wow.
And I went around, and I sat down on the little footstool that was sitting there, and I put my arm around her back, and I said, "Would you like to talk about it?" And she said, "She just reminds me so much of my grandmother. My grandmother only died 6 months ago."
Wow.
Well, if this nurse had had in her daily practice reflective practice and self-reflection, she would not have had that experience in the same way. She would have been ready, maybe, because what we talked about then is what's important is not that people die, but how we facilitate their transition.
Exactly.
That we help make sure they're comfortable, that they're loved, that there's someone is with them. That's what's important. Physical death is a part of life.
It truly is.
But we need to help the energy transmit. We need to be there to help that part of the human being, their soul, go on. So that was an experience for me that I thought was really important. When I talk to nurses about self-care, I say that it helps you if you really take the time to prepare yourself, reflect, meditate, whatever works for you. Some like yoga. Some like to just binge on Netflix. I mean, there's all kinds of ways to do it.
Yes.
But do it on purpose so that you are prepared to be connected to that other human being and be there with that person in a way that will facilitate them as opposed to draining them. I don't know if that's what you were looking for.
No, it's exactly what I was looking for.
Okay.
Working in a teaching institution, there's sometimes conflict between, especially with residents and nursing, because especially experienced nurses. So what do you suggest as an experienced nurse trying to make sure that your patient gets the best outcome, but you're in conflict with what the resident is suggesting?
Well, there's a lot of things. I think some of the things that are more cognitive and maybe scientific that I would say would be we need to understand our communication. 65 to 70% of what we say is nonverbal. So pay attention to how you're communicating with people because your nonverbal cues are more powerful than your verbal ones. And when nurses and doctors get in conflict, nurses very often get into a defensive mode.
Correct.
And rather than doing that, if they stay open, keep their bodies open, and keep their voices softer, and then communicate with them. And I've often said this, of course, the older you get, the more privilege you have. You know that. Well, you don't know that yet, but you will know that as you get older. I've often said to them, what would you do with your mother if this were her situation? What would you do with your brother? And I did that when I was 35, and it worked. But you have to have that non-defensive mode, because nobody's going to respond to you in the way you're hoping, which is collaborative approach. If you're really in defensive mode, that just puts them in defensive mode, you know.
That's true. That's true.
So learning to value what you say and have voice around what you say is really important. And this is one of the things I think that why nursing theory is coming back. You know, it's sort of gotten hidden for a while, but the Academy has put it out as one of its projects. And there's a number of conferences that are going on right now, and a number of activities that are going on right now, like the nurseology.com on the website, that are really important, because it's all about nursing theory. And what theory does is it gives nurses, it's like a roadmap. And without that roadmap, we go hither, dither, and yon.
That's true. That's true. You know, since you were talking about some of the suggestions from and some of the things that are going to be on Nurseology, what do you suggest, or what would, if you were the dean of a nursing school, well, how would you change that curriculum to make sure that it is aligned with what is needed for patient care today?
Well, the IOM study said that we needed holistic approaches, and nurses need to practice to the fullest of their educational abilities. I believe that. The problem we have is many of our educational programs have gone to a biomedical model, where we really emphasize the disease and the conditions as opposed to the holistic health and well-being of people. Now, people can die healthy, okay? They can die healthy if you believe health is a humanistic model, where it's mind, body, spirit is combined in such a way that people are at peace and make the decisions that this is what I want to do. So there's a whole need in education to shift from teaching students at the very beginning how to take temperatures and how to do vitals. That's about the physical being. That is not about the person. That is not about the person. Your personhood leaves you when your physical being is still there.
That's true.
And so I have said, in fact, I did this at Michigan, and it was remarkable. It's one of the things that actually pushed me into being where I am today, is that I said we have to teach communication first. We have to teach the nurses how to understand themselves, communicate within themselves, and communicate with other people. And instead of students going into the unit to take temps, make beds, baths, whatever, they need to learn to go in and say, hello, I'm a student nurse and I'm here to learn about you today. Can you tell me something about yourself? Those students were remarkably different when they came to doing the simulation labs. When they learned that they were an instrument of healing, they were the most important thing in terms of that what happens with that person. Those students were very different than the students who start out with, in educational processes, start out with learning the vitals and learning physiology, et cetera. There's a place for all that.
Yes.
Please don't think I'm not thinking that. And to that extent, I've been working with the American Holistic Nurses Association and the Credentialing Association, and I've chaired a task force for them for several years now. We've just published in October of 17, published the Nursing Curricular Guidelines for basic to doctoral holistic nursing education. This all within this model, and it's consistent with ANC essentials. So we're moving in that direction.
That's great. That's great.
Thank you.
One of the things we deal with on a daily basis is, you know, we've talked about end of life. What kind of recommendations do you have for a nurse who is in conflict with what the patient wants? So, for example, end of life, I've decided I don't want to have CPR or anything like that, but the nurse feels like they should do it. What recommendation would you give that nurse?
Well, it takes me back to the very first question. Where do you start? You start with, what do you believe? And if you don't believe that the client has the right to make decisions, now there is some clinical judgment in that. You have to also be thinking about what else is going on with this client. Is this person so depressed that they're making a bad decision?
Yes.
But when somebody is really terminal or really in a state of lack of quality of life, they're unhealthy from a eudaimonistic perspective, then do they have the right to make that choice? We know people at the national level who made that choice just recently, that this is not what I want. I don't want to go back into the hospital. I don't want that. I want to be able to peacefully pass in my own home. And I think that that is very important for nurses to go back to their philosophy and say, why is it that I am holding on to the biomedical model where you cure, you don't care. It's not about caring, it's about curing, and you can't cure it. So what are we doing to them and what are we doing to ourselves? I think that's very difficult for some nurses. The other part to it is always stepping back and saying, if it were your mother, what would you do?
That's true. That's very true. Well, we have a busy trauma department, and we have a huge emergency room department. And the emergency room or the emergency department is where I have probably my biggest turnover of nursing staff. And those patients don't stay with them, but yet that is the department where I have a high turnover. What are your thoughts in regards to that, and what are some of the things that we can do to try to combat that turnover?
Well, I'm going to give you an example, and then I'll talk a little bit more about it. St. John's system in Detroit is a very big system as well, and they started on this project for the same reason a number of years ago, probably 4 or 5 years ago. One of the things that they've done is set up in the units, not too far from the ER, but on the units all through the hospitals, what they call healing rooms. A little closet, little janitor's room that could get moved over to the side a little bit, and the nurses have a little space there with candles and just quiet space where after a traumatic event they can go and recover themselves for a few seconds. I think we treat ourselves like machines. I was head nurse in an ER one time. We had no residents or interns there, so what I got. We treat ourselves like machines. We think that we're supposed to be able to do all things and go from one thing to another, to another, to another. And that's just not human. So if we can learn, nurses can learn how to center themselves. Back to the nurse again. If they can learn how to center themselves, it takes practice at first. It might take 15 to 30 minutes at first. But when you learn to do it, I can do it in 5 seconds.
Wow.
Okay, so I can go from one traumatic experience to another traumatic experience. And I think we need to teach nurses how to do that, because if they don't, they do burn out. They're using up their energy. And from a biophysical perspective, we know that you can only stay in that hypertensive, hyper alert mode for up to 3 days before the adrenals become depleted. And adrenals are extremely important for your immune system. So, you know, there's a biophysical reason for us to think like this. But one of the things that some of the hospitals have done is first of all, have the discussions. You have to talk about the philosophy. Do you believe this? And then how can we make it happen? The other thing is, how can you, Nurse A, help Nurse B when you see Nurse B's husband just died 6 weeks ago and she's got a man about his age and he's dying of a heart attack? How can you go over there and just pat her on the back and say, I got your back? That's all you have to do sometimes with people. Once that they have the internal resources built, that they're able to then move on. And I think it would cut way back on the attrition. Nurses go into ER and ICUs because it's exciting. Too much excitement can kill a person, you know. So we have to, physically, it's really hard on people to have that hyper alert. Selye told us that years ago. And it's very much a part of the work that I do in modeling and role modeling, is looking at their ability to cope. We didn't talk about that at all yet, but one of the early things that I discovered was it's really not whether people are in stress or not, because nurses would come out and say, that guy down there, he's really stressed. Well, the question for me is, are they able to cope with that stress? And so I developed a model. It's called the Adaptive Potential Assessment Model. And you can, using that model, you can determine whether or not the person is able to cope, to pull those resources that they need to contend with it versus those who aren't. Those who aren't need a very different kind of intervention than those who are. And it's true about us as human beings, learning how to recognize that in ourselves. So it's informing, helping them become informed about the possibilities that they have, the resources they have, and it's okay. It's really okay to take care of yourself first. You know, in the nursing literature, younger people don't know this, but in the nursing literature, it never said anything until 1977. Letty and Pepper were the first people that wrote in there that nurses have to take care of themselves. And before that, it was just assumed that nurses knew enough to do that, but we didn't. So I don't know if that answers your question.
It did. It
Okay,
did.
good.
You know, we are very fortunate here in San Antonio that we have many schools of nursing, and we have a lot of our staff who have advanced degrees. What would you recommend to a novice researcher, based on how you went through your journey, if they wanted to get further into nursing theory? What are some of the suggestions that you have for them?
Well, they can develop their own theory, of course, or they can draw from the theories that exist. But none of it's any good unless it really fits their practice and their philosophy. And so from my perspective, if philosophy and practice don't go together, you've got a problem. And if practice and research don't go together, you've got a problem. So again, it goes back to, what do they believe? What do they think? And where's their orientation? You know, we used to have the art of nursing be the big thing. And then in the 60s, they brought out the science of nursing and the nursing process and so forth. And with that, we sort of threw away the art of nursing. Over the last 10 or 15 years, we've realized, oh, we made a big mistake. We have to bring back the art of nursing. I think it's the interweaving of the art and science that makes the practice, and that creates the theory. So it's extrapolating. All of modeling and role modeling came from practice. And then, of course, there's been, I don't know, a lot of research has been done since then. I've supervised over 50 dissertations myself.
Wow.
So, and there's people
That's
all
wonderful.
over the country, all over the world actually, that have researched using it. So they've expanded the work. But to me, I don't know, for myself, I cannot separate practice and research. Some can. I would say then that that's a very good way to combine PhD and DNPs. Because I think our educational programs for the DNPs are really about practice. And the PhDs are supposedly better researchers.
Yeah.
So let's get them together.
Yes.
And let's talk about what is it that you're seeing in your practice setting that tickles your fancy or that stimulates your curiosity. That, wait a minute, I'm not quite sure that's the way it is. And if that were my mother, that's not how I would want it to be. And let's use that to bring up new research and bring up new theories. And I think with nursology, what we're going to find is that there's an underpinning in all of our nurse theories. I just did I'm working on a model that shows the different paradigms we are using in nursing theory. And talked to Jackie Fawcett about this a little bit. I'm probably going to publish it on Nursology. That nursing really has 3 different paradigms that we're using. And one of them is what Parsi would have called the totality model, which is really, you take people apart, put them back together and call them a whole person. But there's the body, the mind, we're psych nurse, we're med-surg nurse, you know, that kind of thing. The second one is integrative, interactive, and that's more along the line of what I'm talking about. And the third one is the unitary person that Rogers talked about. Now, when I look at those, I see that there's a commonality under them. But when you just look at the paradigm itself, they look very different. And I think nurse educators and nurse researchers have to pay some attention to this and start to ask themselves, how does what I'm doing relate to each of those paradigms? And how do I want to make sure that it connects with each one? Because with Roger's work, what she talks about is a unitary human being, that everything is energy, so everything is connected. We're all connected.
Yes, we
In
are.
this room, outside of this room, everything is connected energetically. How do we use that purposefully? That's the question that Rogers would have. I have that question too when I say, it's my job to understand that other person's worldview and start with that. I have to be connected to that human being. So I think the very basis of person-centered caring is what Rogers is talking about, is that energetic connection. And so, but at the same time, I think we also have to be able to understand the immune system and those pieces of the person. So it's bringing those three paradigms together and finding the commonalities that researchers have got to do. Because right now they take it and they run with a little tiny piece, and then they know about one thing, but they don't know how that affects anything else. So that's what I think.
That's awesome.
Oh, thank you.
Well, Dr. Erickson, we have really enjoyed talking to you today about your theory, and we appreciate you coming to University Health System and sharing your knowledge with us. And I would like to ask you one final question.
Okay.
And that question is, if you had the opportunity to do anything different with your theory, what would you have done differently?
Well, I've thought about that a lot. And of course, writing more would have been one of the things, but writing more means I'm talking less. And I'm not quite sure which is more influential. People have read a lot of what I've written, and it's in all of the theory books now and so forth. I'm not really sure I would have done too much different. I do want to revise the first book, and that's a goal. I think maybe over the next year that will be done. But differently, I don't know. I think standing my course. I have a family, and my self-care is to be with my family, be there when they need me. I have 4 children, 8 grandchildren. They all, we all gather a lot. So I wouldn't miss any of that. When I was about 35 years old, I had an experience where I was told, either you show up for work today or you don't have a job.
Oh, wow.
And my little boy was 2 and he had measles and mumps. And I said, I'm his mother and I will be home with him today. I'm not coming in. I called plenty early. I was staff nurse at the time. And of course I found out that I didn't lose my job or anything like that. But when I thought about that in self-reflection, went back on it and thought about it, I thought, what's really, really important to me is to figure out who I am and live by my values. And sometimes that's going to mean I might lose a job, or I might not get a job I would like, or people might say she's a crazy. When I first put this out, I was called a lot of funny things. But what's really important, and I said to myself, when I'm 70, I want to be able to look back on my life and say, you know what, I knew this was right, and I stuck to my values. And so I don't think I would have done anything different with the theory. I would have let it live its life, and I've always said, if it has merit, it will live on beyond me, and if it doesn't, it'll go with me, and that's okay. That's okay. So.
Well, I want to provide you a personal thank you. Because my research was in emotional intelligence.
Oh, yes.
But it was initiated through your research. The modeling and role modeling led to the self-awareness and relationship management, all of those things that I wanted to learn. But the foundation was your modeling and role modeling. So I want to thank you for that.
You know what you just did is you met my growth needs. What can I say? I love it. Thank you so much, Simon. That's
Thank you
just
for your
such
time
a
today.
joy. Thank you.
Appreciate you.
It's my pleasure to be here.